Okay, so again, good evening, everyone. Again, I'm Randy Kearns, your professor for HCM 2000. And this week we will cover Medicare, Medicaid, and federal health care type programs. So let me start by pointing out just a couple of things. First of all, just a reminder, the university is moving back to a phase of operation. I think it's phase 2, but it does allow us to be on campus, and we will be on campus next Monday night, and we will continue to be on campus every other week for the remainder of the semester. I think we have either 4 or 5 more classes where we will be on campus, but our next on-campus class will be next Monday night, and we'll be in, again, Kirschman Hall, room 122. One other thing, if you did attend class last week and you've not sent me a note to that effect, please let me know. Also, if you were unable to attend the class but attended online, and you haven't sent me a note about that, be sure and send me an email to that effect as well. The other thing I'll point out is our quiz. There will be a quiz this week, again, dealing with federal healthcare programs, primarily focusing on Medicare and Medicaid, but we will see Medicare and Medicaid are 2 cornerstone components of the American healthcare system, and so we will see a lot about that this week and weeks to come. So without anything further, let me go ahead and switch to, actually, let me be sure I'm sharing my screen. I want to share this screen. Okay, so you should be able to see federal health care, including Medicare and Medicaid, and again, the focus is Medicare and Medicaid, but also some of the other federal health care programs that are much smaller in size compared to Medicare and Medicaid, but they are important as well. So let's start out with our terms. DHHS is the overarching federal organization that manages pretty much all of the federal healthcare system. DHHS is the Department of Health and Human Services, and contained within DHHS includes CMS. CMS is the Centers for Medicare and Medicaid Services. It also includes other programs. It includes the Centers for Disease Control and Prevention. It includes the Agency for Healthcare and Quality. There will be, well, VHA, TRICARE. Again, some of these other programs we'll talk about later on tonight. Most all of them fall up under DHHS, the National Institutes of Health, the National Academies of Science. Anyway, if it's healthcare related, chances are it falls under DHHS. The other key term is diagnostic related group. Again, we've seen that before. We'll see that again. That's basically where a related group of diagnoses fall under one category, and it's a bundled payment. It came into effect in the early 1980s under the prospective payment system, and it's been adjusted through the last 40 years. But the DRG is a primary means of understanding payment classification for all of healthcare, not just Medicare, but Medicare certainly drives the DRG system and defines the DRG system. The Social Security Act, I've mentioned this before, but again, just to be sure and go over it again, Title 18 of the Social Security Act specifically discusses Medicare, Title 19 discusses Medicaid, and Title 21 discusses CHIP, the Children's Health Insurance Program. And in case you were wondering, Title 20 actually deals with social services and aid to families with dependent children. But anyway, for the healthcare part of this, we primarily need to be concerned with Title 18, Title 19, and Title 21. For public insurance, I'll break that apart into Medicare's Part A, B, C, and D. The first two were Parts A and B, and then C and D came along at two other times in life. So how do we pay for Medicare? Most of Medicare, if you look at your check whenever you go to work at the end of 2 weeks or at the end of the week or at the end of the month, whenever you get paid, you'll get a paycheck, but taken out of your paycheck includes things like federal income tax, state income tax, and there's somebody on there getting a bit of your paycheck called FICA, the Federal Insurance Contributions Act. FICA is designed to pay for Medicare. So right now, if you're working, you are paying for Medicare. And hopefully, as long as people work together, there will be Medicare around at the time you reach the age that you can retire and you can use it too. Medicaid and Medicaid expansion, we will speak specifically to that later on, but Medicaid again is means tested. It's based on people, it's primarily for people who are financially disadvantaged. CHIP, also known as SCHIP, is the Children's Health Insurance Program. That's a way to expand Medicaid for children of families who are poor but don't meet the classification of being so poor that they qualify for Medicaid. We frequently refer to that group of people as really the working poor. Chances are they work for a living, but they may earn minimum wage or barely better than minimum wage. They may earn just enough money to not qualify for Medicaid, but not earn enough money to be able to pay for health insurance. But their children can receive health insurance through the CHIP program. And they may today be able to receive health insurance through Medicaid expansion. But again, we'll talk about that later. If you're a veteran or active duty military, if you're a veteran, you can receive health care through the Veterans Health Administration. We have a large VHA hospital or a VA hospital in the greater New Orleans area. But there are also VA clinics around the country now, and a number of clinics have been built with the intent of trying to serve veterans. The VA 15 years ago had a great reputation, and it was considered some of the best healthcare in America. What happened between 2005 and today? We took on war on two fronts, Iraq and Afghanistan, and we didn't spend the type of money that was necessary to ramp up for those soldiers coming home, soldiers, Marine, Airmen. But the point is, not a lot of development occurred in the VA between 2005 and 2010, and suddenly there was this tremendous need and a lack of resources to meet that need. And we'll talk a little bit more about that later on. If you're active duty military, you use something called TRICARE. It's formerly known as CHAMPUS. You may see some literature still talk about CHAMPUS, but active duty military has an insurance card called TRICARE. And again, we'll talk about that a little later on too. Let me let one of your classmates in. Private insurance, although it doesn't really fall under the federal aspects of healthcare, sometimes there's an insurance program or product out there sold called Medigap. And what Medigap does is Medigap pays for your copays and gaps in coverage below what Medicare will pay for and what's basically your out-of-pocket cost. Medigap is, again, it's a private insurance product, but sometimes there's some confusion that people think Medigap is a part of these Medicare programs. They're not, but sometimes they're essential to help people limit their out-of-pocket costs. And as I said before, Title 20 of the Social Security Act is the Social Services Block Grant. So let's talk a little bit about public insurance. If we add all of this together, you come out to about 35%, just over 1/3 of all who are insured are either covered by Medicare, Medicaid, or some type of government health care, VA or TRICARE. Just the number of VA hospitals in the country and the number of active duty service members who use TRICARE, in the total number of people there, it's 325 million people in the United States. Obviously, a small number of those are active duty military or retired military relying on the VA or relying on TRICARE. But nevertheless, those numbers are there and do account for about 2% of those who have some type of government insurance. And then Medicare and Medicaid, again, just a reminder, Medicaid is for the financially disadvantaged. Medicaid is considered a state program that's operated as a partnership with the federal government, as opposed to Medicare, which is a federal-only program. Earlier, I mentioned the Department of Health and Human Services. This is the array of different organizations that are under DHHS. The ones that we primarily know the most about include CMS and AHRQ and FDA, but obviously there's a substantial number of people who work under the Department of Health and Human Services. And again, all of the things that we do in the American healthcare system that has federal involvement primarily works through DHHS or connects to DHHS. The largest or the most active of the organizations, at least that we primarily deal with in the hospital world, is CMS, the Centers for Medicare and Medicaid Services. Again, remember, Medicare was created for retirees, people 65 years of age and older, and then Medicaid was created for those who were economically disadvantaged. There may be a chance as you're reading any of the older materials where instead of it talking about CMS, it talks about HCFA. HCFA was the Healthcare Financing Administration. HCFA changed its name to CMS in the 1990s, but there are some documents that I may reference or we may use from time to time that may refer to CMS as HCFA. Just understand the two are interchangeable. HCFA is the old name for it. CMS is the name that we've had now for about 25 years. One point about, well, I'll talk about Medicaid later. So one other reminder, although it was signed into law in 1965, it actually didn't begin to operate Medicare and Medicaid until 1967. It took a couple of years to put the pieces in place to make this work. And as I've said before, Medicare is a federal program, and so effective immediately in 1967, everyone who was 65 years of age or older qualified for Medicare and could use Medicare. Medicaid is a state-by-state decision and a state-by-state program. And just as not every state has chosen to expand Medicaid, which I don't think is a good idea, but nevertheless they have it, not every state in 1967 chose to expand Medicaid or chose to accept Medicaid. And so there were a dozen states or so that did not have Medicaid when this program began in 1967. So again, as I've mentioned, Medicare is Title 18 of the Social Security Act. Probably the one big thing that has changed in the last 5 years. There was a law passed called MARCA. I'll show you MARCA in just a minute, but one of the key pieces of MARCA, it reauthorized funding for CHIP, But another key piece of MARCA included directing CMS to change the Medicare cards. The Medicare card in up through 2019 included your Social Security number on it. And so if I wanted to steal your identity, it would be much easier for me to do that if I had your Medicare card than say your Social Security card. And so part of MARCA in 2019 was to eliminate using Social Security numbers as a part of Medicare. Just understand our use of Social Security numbers and our decision to believe that information now should be guarded and protected has changed dramatically. A lot of years ago when I was in college, we used to write our Social Security number on all of our test papers. And in fact, our grades, when our grades would be posted, they would be posted by Social Security number. And so the world has really changed in a way that has gone from using the Social Security number for a lot of things, which included the Medicare card, to using it for very few things and protecting it because guarding your personal information is important. So let's kind of get through eligibility for Medicare. Originally, Medicare was designed for people who are 65 years of age or older. A couple of years after it was implemented, it was also expanded to include people who were disabled. If you became disabled and qualified for drawing Social Security benefits, then you also qualified for being eligible for Medicare. Medicare was also expanded to cover a very small segment of patients that really don't have anything to do with Medicare with age 65, but it does have to do with disability, and that's people who have end-stage renal disease. End-stage renal disease means your kidneys have failed and failed to the point that you are on dialysis and you have to have your blood dialyzed every 48 to 72 hours. So last week when we looked through dialysis, when we looked at dialysis machines, just understand people who wind up needing that machine to cleanse their blood every 48 to 72 hours are eligible for Medicare regardless of their age. And so there are four parts of Medicare: A, B, C, and D. Again, as I mentioned before, Medigap is a private insurance, but a lot of people use Medigap as a supplement to their Medicare. Let's talk about what Medicare doesn't do. Medicare doesn't include any type of benefit for vision or eyeglasses or dental care, hearing aids. Most long-term care services are not included in Medicare. Now, the caveat here is it can be included if it's a part of a Part C program. I'll have more to say about that when we get to Medicare Part C. So with Medicare Part A is financed by payroll taxes. It's paid by all working individuals. And Medicare Part A is the hospital insurance. So if you're hospitalized, Medicare Part A covers your hospitalization, or it covers 80% of the approved cost for your hospitalization. And I'll talk a little bit more about those words in just a minute. But the big picture is Medicare Part A covers hospitalization. Medicare Part A was set up to closely mirror Blue Cross because Blue Cross existed in all 50 states, and Blue Cross was a commercial insurance product. And so when Medicare was started, the federal government contracted with the Blue Cross offices to basically administer the Medicare program. And so in many cases, Medicare Part A and Blue Cross had the same set of rules or very similar rules for how to make payment and how to process claims. So the reason Medicare Part A looks a lot like Blue Cross is because in most cases, Blue Cross employees, each Blue Cross organization in each state was contracted with by the federal government to provide claim service for Medicare patients. Other parts of Medicare financing is to understand how the money is spent. As you can tell by this, more than half of the money spent is spent on hospital care. So the balance is then split between SNFs. The SNF is a skilled nursing facility. A nursing home or a nursing facility is a SNF. Home health gets a small piece of the pie. Hospice gets about 5%. Managed care, we'll talk about managed care in a minute, and then administrative cost. But it gives you an idea of, for all of public financing, more than half of it goes to hospitalization and Part A expenditures. Now this was about 9 years ago, so obviously it's not terribly current, but it does give us an idea of what the trends have been and what the trends, for that matter, continue to be. Again, if we look at public financing and Part A, there's other parts of the benefit. There is a skilled nursing facility benefit, but it's a lifetime, one-time benefit. And so what that means is, let's say I've been in the hospital and I'm 75 years old and I qualify, I have Medicare, and I have knee replacement surgery, and I have a joint replacement. And so I'm only going to stay in the hospital a couple of days for my knee replacement surgery, but I need to spend some time somewhere in rehabilitation so that I'm able to regain the function of my knee, and I'm able to be able to walk again. And so a part of that may include me being sent from the hospital to a nursing home to receive rehab services. And so the first 20 days of that, the first 20 days of staying at a nursing home, I am eligible. The first 20 days of staying in a nursing home, I am eligible for Medicare coverage. Now, at no charge to the beneficiary, but starting day 21 through day 99, if I stayed up to 100 days, there's a reduced benefit that's available. But after day 99, I have no additional benefit. And that's a one-time and a lifetime benefit. So if I use it when I'm 70 and then when I'm 80, I have the other knee replaced, I may not have it. I may not have the benefit to use again. Or if I do, it's what's left of that 100-day benefit that I get. Just understand that there's a maximum one-time lifetime benefit of up to 100 days. And the first 20 days are no cost out of pocket. The next 80 days are based on a co-insurance. And after 100 days, there is no additional benefit to a Medicare patient in a nursing home. Well, if you've ever been in a nursing home, you know that there are a lot of people in there who qualify for Medicare. Just understand that Medicare doesn't pay for their skilled nursing care in the facility. It doesn't pay for the bed. It doesn't pay for them to be able to stay there. The only program that pays for someone to stay in a skilled nursing facility that's federal insurance is Medicaid. Medicaid, if you're financially disadvantaged, will pay for that, but not Medicare. Other things Medicare Part A covers: the home health benefit if the patient's homebound, and the hospice benefit, but the patient must have a non-terminal irreversible illness, and they have to be certified to have a non-terminal irreversible illness. Typically, patients on hospice, hospice is end-of-life care. Typically, when somebody goes into hospice, they're only on hospice for a couple of weeks. Now, in rare circumstances, people may actually live longer than 6 months. And if they do, that's okay. You can get recertified for additional periods. Again, it's very unusual for people to live more than 6 months on and in hospice care. Other parts of Medicare Part A, again, timing depends on the benefit period. It starts with the when the beneficiary is hospitalized, um, and typically there's an unlimited benefit period. Just to understand, Medicare Part A primarily deals with hospitalization, and Medicare Part A looks an awful lot like Blue Cross, because in the early days, Medicare Part A was created and contracted with the Blue Cross companies around the US to administer Medicare Part A. Now let's talk about Medicare Part B. Medicare Part B primarily covers physician services, outpatient services, diagnostic tests, x-ray, ambulance service, durable medical equipment. Typically all of those things that's not in a hospital. If I had surgery as an inpatient in the hospital, then that's Medicare Part A. But if I had outpatient surgery where I had some type of procedure and it was done over at ambulatory care and it was done within a couple of hours and I go home, that's covered under Medicare Part B. Medicare Part B looks an awful lot like Blue Shield. And the reason Medicare Part B looks a lot like Blue Shield goes back to my original statement, and that is when Medicare was first established, they contracted with Blue Cross to administer the hospitalization program and Blue Shield to administer the doctor's office Part B services, radiology, ambulance, durable medical equipment, all of those things that typically aren't a part of the hospital stay. In the early 1980s is when Blue Cross and Blue Shield merged. But until that time, they were actually separate companies in most states. And so, again, Medicare Part A looks an awful lot like Blue Cross, and Medicare Part B looks an awful lot like Blue Shield. And that's the reason behind it. Another piece about Medicare Part B that's different than Medicare Part A, Medicare Part B has an annual deduction, and then there's also a monthly premium cost that's paid, and then there's a co-insurance of 80/20. And what that basically means is if the service cost if the service costs $2,000, but the approved amount was only $1,000, then the co-insurance is 20% of the approved amount. So let me say that again. If the service would have cost $2,000, but the approved amount is $1,000, and the co-insurance is 80% of that, then it's $2,000 minus $1,000 that nobody has to pay. So the only thing left is the approved amount, that's $1,000. And then 80% of that is paid by Medicare. So 800 of the $1,000, 80% is paid by Medicare. And you're responsible, as the beneficiary, you're responsible for the other 20%, which is $200. And that's why some people have Medigap insurance, is to pay that other $200 with Medigap insurance instead of having to pay that out of pocket. There are other parts in the Medicare Part B, an annual wellness exam and certain screening and preventative care measures. Part C is really a managed care version of Medicare. Part C was created during the Balanced Budget Act of 1997, and Part C was created in a way to allow private insurance to administer the Medicare program by combining A and B, and then in some cases adding additional services. But just understand, managed care substantially limits the doctors you can go to, the hospitals you can be taken care of in. And as long as you understand those limits, you can typically get a better deal by having Medicare Part C than paying for the traditional Medicare Part B and receiving Medicare Part A. Again, C combines your A and B benefit, and and in most cases gives you an additional service. In some cases it's vision care, in some cases it's hearing aids and vision care, in some cases it includes dental care. Now, that was in 1997. In 2003, the Medicare Modernization Act was passed that included the prescription drug benefit, which was Medicare Part D. And the reason I mention that, particularly in the context of what I was just talking about, if you sign up for Medicare Part C today, Medicare Part C bundles your A benefit, your B benefit, and your D benefit. Okay, Medicare Part D is your prescription drug coverage. So you otherwise have three components, A, B, and D. And if you sign up for C, C combines those three components and they administer it under one umbrella. So you have some choices, but you'll also have some limitations. But you can save some money signing up for Medicare Part C and receive some additional benefits. So let's go ahead and move to Medicaid. Again, Medicaid is Title 19 of the Social Security Act. It's means tested. It's based on assuring people with the least among us have some form of health insurance. Each state has to file its own plan of how it plans to administer Medicaid. The federal government creates a given set of rules that everyone must follow, but within the confines of those rules, there is some variability. So what that means is if I have Medicaid in Louisiana and I had Medicaid in Texas, I may have a different set of, I may not have exactly the same number of benefits in each state. It's also important to note that Medicaid is predominantly managed care in a managed care type service in every state in the U.S. Just as I mentioned earlier, it is voluntary participation. So by January of 1968, only 37 out of 50 states joined Medicaid. Arizona was the last one to become a participating state. And we've seen some of the same thing with Medicaid expansion. I'll talk about that in just a minute. But right now, let me go ahead and move to the Children's Health Insurance Program. CHIP, I don't have it included in this slide, but CHIP also was created during the Balanced Budget Act of 1997. Just as a reminder, during the Clinton administration, President Clinton had worked hard to try and create some type of a national health system, but got distracted, did some crazy things, and was unable to deliver on what he saw was an important piece of legislation. But one thing he was able to do was in the negotiation to create a balanced budget, and that was when Republicans and Democrats, they still hated each other, but they still negotiated to pass legislation. Each side saw a value in passing legislation. Today, we just seem to be more content at screaming at one another from time to time. But nevertheless, the Republicans and the Democrats came together to create the Balanced Budget Act of 1997. Well, key pieces within that created the Critical Access Hospital. It created Medicare Part C, which was the Medicare Advantage program, also known as the managed care version of Medicare. It also included the Children's Health Insurance Program. And so, again, these were vital pieces that didn't exist before the Balanced Budget Act of 1997 and came about through this large reconciliation process where there was negotiated decisions made that included Republicans supporting it and Democrats supporting it. CHIP is one of those types of programs that no matter what your beliefs are about poverty, and there's some fairly strident views about, about people living in poverty, that there's an attitude out there, well, they just need to go get a job. Sometimes it's a little bit harder than that. Sometimes it's a lot harder than that, but not everybody believes that. But the one thing everybody does believe, or most people believe, is children shouldn't have to, we shouldn't leave children being the pawns in this. If children need health insurance, they need health insurance. And let's argue, discuss how we feel about parents as a different discussion. The reality is, if children are living in poverty, they need some form of health care, and CHIP came as a result of that. Again, in some cases, you'll see it described as S-CHIP because some parts of the political argument is this is a state program, and so it should be the state children's health insurance program. So in some cases, you'll see it referred to as S-CHIP, but in most cases, it's just referred to as CHIP, Children's Health Insurance Program. Again, it's a family living in poverty, but living above the threshold to qualify for Medicaid, but still living in poverty at a level that allows the children to qualify for health insurance. And it's basically an expanded form of Medicaid for children only. So the Affordable Care Act and public insurance, there were a handful of things that were included in the Affordable Care Act. One piece was each state was left to decide whether it wanted to expand Medicaid. And so that's why you've seen this dichotomy of states out there that did not expand Medicaid and those that did. Now, early on, it broke straight down party lines. If you were a state primarily controlled by Republicans, you did not expand Medicaid. If you were a state controlled primarily by Democrats, you did expand Medicaid. Where that changed pretty early on was there were a number of states that were led by Republican governors, but they did the math and they realized, whether my state accepts Medicaid or not, my residents of my state are still paying those taxes. And so, if I want that money diverted back to my state that my residents are paying, I probably need to accept this. And so states like New Jersey, Governor Chris Christie at the time, a Republican, led the state of New Jersey. He was one of the first to accept Medicaid expansion. Ohio was led by a Republican governor by the name of John Kasich. He also felt like it was more important to have the money come back to Ohio and they would figure it out. And then you have seen that argument around the country begin to pop up. And the reality is, again, if you do the math, all you're doing is turning your back on millions of dollars that should be and could be coming back to your state to provide health care. I don't know of a political argument that trumps that, but nevertheless, that seems to be the case in at least a handful of states still out there. In the state of Louisiana, before we expanded Medicaid, 22% of the entire state's population had no form of insurance. After expanding Medicaid, 9% of today's state's population has no form of insurance. Still bad. That's still almost 1 out of every 10 people who don't have some type of health insurance. But there's a big difference between almost 1 out of 10 versus almost 1 out of 5, or more than 1 out of 5. And so it is better. It's just not great. And we need to keep working on the ways to make it better. Other aspects of, again, health insurance expansion or Medicaid expansion. So if we look at, this is 2013, the orange states did not expand Medicaid. The states in blue either had expanded Medicaid or were in discussions to expand Medicaid. This is 2013. And then this is, I think this is, 2018. And this gives you an idea. And Alaska, as an example, is a committed Republican state. but Alaska also recognized that it just makes more sense to bring those dollars back to the state of Alaska. And again, if we look at the states that remain, it's primarily states in the Deep South. And then actually, if we look at the April of 2019 and then the April of 2020, how many states are left? There's really only a handful of states that have not expanded Medicaid. And again, it's a logical conclusion, but logic and politics don't always work together. So that's where we have it. Federal health care aside, let's talk about other aspects of federal health care. I have about, where am I at? I have about 19 minutes left. Let me be sure and hit a couple of these things. Even if I don't finish all of the slides tonight, I do want to hit the highlights of what's left. The VA Health Service, I talked about that earlier. Historically, Champus was what active duty military, it was the insurance that they had that was provided to them. Because there were three options, Champus developed three options. It became more commonly known as TRICARE, and today that's what it's referred to as, is TRICARE. Again, historically, the nation's first national health system was the U.S. Marine Hospital System. We've talked about that before. It later became the U.S. Public Health System. But there's Champus then became TRICARE. VA primarily operates a hospital and healthcare system for veterans. Now that's primarily service connected, but if they have capacity, they will take care of any veterans' needs for any healthcare needs. But again, the first priority is service connected injury and illness. So as an example, my dad was a veteran, and I remember him going to a veterans hospital for surgery for a kidney stone. Obviously, that had nothing to do with his service, but because he was a veteran and they had available space and available care, they provided that care for him. The military health service is slightly different. If I'm at a large military base, in some cases there's a hospital on that base. Actually, I think I've got a slide for that. The Indian Health Service, I'll talk about that in just a minute. There are 4 recognized Native American tribes in the state of Louisiana. And then there's also a healthcare system at the Bureau of Prisons that's a part of the federal prison system. Again, just a reminder about the U.S. Marine Hospital System. It was a tax on wages of seamen, and the whole purpose to that was to create a hospital system around the country at ports where seamen may come ashore either disabled or sick and away from home and in no means to care for themselves. It was renamed the U.S. Public Health Service in 1912 and expanded to include sanatoriums. As a reminder, the leprosarium at Carville was a part of this, the only leper colony, so to speak, in the continental U.S. And Carville is, if you don't know where it's at, it's about 2/3 of the way between here and Baton Rouge on the west side of the Mississippi River. Most of the public health or the old hospitals of the U.S. Marine Hospital System closed by 1972, and the ones that remained all closed by 1982. But the Commission Corps of the Uniform Public Health Service does continue to function. And if you have military service and you're interested in pursuing a master's degree, I would look at considering the Uniform Public Health Service Commission Corps. I've had a couple of friends who served in the Commission Corps. During peacetime, during wartime, they're assigned to the Navy, but during peacetime, they have civilian roles, either at Native American tribal health as a part of it through the Bureau of Indian Affairs, maybe the Bureau of Prisons. A lot of them is involved in disaster response and disaster operations. If we have a little bit of time, I can show you that. If not, I'll at least include the link. Yeah, here's the link for the Uniform United States Public Health Service Commission Corps. Again, the Commission Corps is at one time was just clinically credentialed personnel, nurses, doctors, respiratory therapists, and pharmacists. But today's does include people with a master's in healthcare management, and because people have to manage some of these organizations. So it may be something worth looking into. U.S. Marine Hospitals on the Mississippi. Again, the one at New Orleans, if you want to see the old campus, it's part of the old campus is still there. It's next to the Children's Hospital, and the Children's Hospital now use the remaining property that they plan to reoccupy. Algiers was the Louisiana quarantine station and hospital. It was operated as a camp for POWs during World War II. The property was sold a couple of years ago. Carvel, I mentioned it earlier. There was a hospital in Mississippi in Natchez. It was transferred to local ownership, and then it burned down about 30 years ago. Vicksburg and Memphis also had marine hospitals. There were a number of other marine hospitals on the Mississippi River because the Mississippi at one point was the most navigated body of water other than the Atlantic Ocean in the history of our country up until the early 1900s. This was an early picture of the U.S. Marine Hospital system in New Orleans as it developed. These are additional pictures of the new construction at the Marine Hospital system. Again, some of these buildings still are standing, but most of the grounds of the Children's Hospital today is where the Marine Hospital system was. And this is the leprosarium over at Carvel. Again, the only leper colony in the United States where a lot of research was done in Hansen's disease and understanding Hansen's disease. So as far as TRICARE goes, let's go ahead and make the change now to talk about Champus and TRICARE. TRICARE is, as I said, the insurance program for people who are active duty military, Army, Navy, Marines, Air Force, Coast Guard, but they have a health insurance program called TRICARE. And TRICARE at one point was Champus, and again, it was the three options they had in Champus was basically the basis for renaming it TRICARE. I do have some health insurance coverage rules as it relates to years of service, as it relates to divorce. I've just included this for your information. There are no test questions on it, but if you want to know more about TRICARE or Champus, it's still there. And if you don't qualify for TRICARE, there is something else called Champ VA, which is similar to Champus for veterans. And so I've also included information about it, again, just to help you understand what's available and what's out there beyond TRICARE and beyond the VA healthcare system. It is this hybrid of Champus and VA Health. Let's see. What else do I want to be sure and talk about? What is VA healthcare? This is the VA hospital in New Orleans. How do you get VA benefits and who qualifies for VA benefits? Again, minimum duty, were you active duty? Were you a member of the reserves or the National Guard? It called active duty. The focus is on veterans with service-related injury and illness. But again, as capacity is available, they will certainly provide additional services to all veterans. Again, depending on what services are needed and then what type of capacity is available. The military health system is different. It basically is for active duty, on post, and certainly the largest bases in the United States still have active hospitals. The only one that I could really find in Louisiana is Barksdale Air Force Base up near Shreveport, where the B-52s are located. There's a military hospital there. Generally speaking, it's a clinic. In most cases, it's a clinic, and they provide good clinic services, particularly during the daytime. But in most cases, those patients are referred out to. There's a lot of good civilian care in most of those large cities, and they refer those patients out to the civilian care. Yeah, so most hospitals have closed other than Fort Polk. The Naval Air Station at Belle Chase operates as a clinic. I'm sorry, the hospital at Barksdale Air Force Base is now operated as a clinic. Camp Beauregard Army Base Hospital now operates as a clinic. And so again, in most of those cases, those clinics have, or those hospitals have closed, and either those buildings repurposed or they've turned them into clinics. Let's see, what else? Fort Polk is the only place where there is an actual military hospital functioning in Louisiana on a military base. But again, in most cases, those Army or military hospitals have closed and been converted to clinics. So let's go ahead and talk briefly about Indian Health Services. Again, the 4 federally recognized tribes in Louisiana. I've tried to identify all 4 of them have some type of a health center. And so I did locate all 4 of those in the greater Louisiana area, or in the across the state. The only one that's somewhat close to us is between Lafayette and New Orleans off of Highway 90. But that's, again, all of the tribal nations have some obligation to provide health care, and that's provided through the Indian Health Service. But it is important to recognize that many of these health services, many of these tribal nations don't have a great deal of financial resources, and therefore provide only limited or only basic healthcare services. There's over 500 recognized, federally recognized tribal nations across the United States. And so I grew up in North Carolina, and so my frame of reference was the Eastern Band of the Cherokee Indian. And the Cherokees in Western North Carolina, oddly enough, the Eastern Band, but the Cherokees in Western North Carolina had good business acumen, and had developed a casino approach and reservation on the reservation, established a contract with Herrera's, and had one of the most profitable gambling casinos in the greater Atlanta area, which is actually less than 200 miles from the Cherokee tribal nation. And so they were able to use that profitability to pour that back into the community, and had some reasonable services, had a very nice hospital and a very nice EMS system. So that was my frame of reference. I worked with somebody a couple of years later who oversaw a lot of the projects in the Bureau of Indian Affairs, and particularly the Public Health Service, Indian Health Service. And some of the conditions she described were just stark poverty. One particular tribe she referred to, they still receive mail by horseback, and the only way into the canyon where the tribal nation lived was also by horse. So all supplies went in by horse. Also, everything went in or came out to the canyon only by horse. And I was really struck by the fact that, you know, this was 6 years ago, 7 years ago. And so just understand of the 500 and some odd, I think 512 defined tribal nations across the United States. Some have been fortunate and and financially healthy and able to provide good services, while others have struggled mightily or have no natural resources to rely on, and therefore are very poor and have very limited services. But I would encourage you, if you have any connections to any of the tribal nations, to understand more about what's being provided. There's certainly volunteer opportunities, and there's certainly opportunities there to learn. Again, if you have any connection, I think it would be interesting to the point of fascinating, to see what's available or what are things that you could do to help. So the last one I'll point out is the Federal Bureau of Prisons, and the Federal Bureau of Prisons are charged with providing healthcare services for everyone incarcerated in a federal prison. Now, having transported patients as a paramedic at one point in my life, either to or from one of these types of facilities, I understand that they're closed custody, in some cases maximum security. There's no urgency to get in or off of one of those campuses. The type of security and the level of scrutiny that your ambulance goes through, or anybody goes through to get into one of these facilities or out of one of these facilities, basically means they come up with ways to try and be as self-sufficient as they can. And the whole point to that is they don't want people leaving to go to a civilian hospital. And so now what that also means is there's a fairly extensive healthcare service that's provided at each one of these federally operated hospitals or prison type facilities. The big picture there is, again, depending on what you want to do with your degree at some point, or whatever discipline you choose to pursue, there are options. There are lots of options. If this is something that you would be interested in, I would at least explore and learn more about it. Again, the reality of this is to look at all of the different services that are available and all of the different things that are provided. With our topic this week being federal healthcare and federal resources, I felt like I needed to give you at least a sense of all of the things that are out there. You know, the vast majority of everything being done in healthcare really focuses on Medicare and Medicaid as the two largest payers. And so a predominant amount of the discussion and the information points back to Medicare and Medicaid. And we can't lose sight of that, but it's also important to recognize these smaller components also have importance. And thus I feel like it's important to be sure and point that out. And with that, that's our conclusion, and that's where we are. Are there any questions tonight?
No, sir.
Okay. So let's wrap it up with this. Again, just a reminder, we will be in class, Kirschman Hall, room 122, 6 o'clock next Monday night. And we will be in class every other week for the remainder of the semester. And I think it's either 4 more classes or 5 more classes. Just be sure and look at where we are on Moodle. That will give you, that will tell you what you need to know about where you need to be next Monday night and the following Monday nights. Be sure and meet your deadlines. If you have any question with something, or if something breaks or something happens in your life, send me an email. We'll deal with it. But I appreciate everybody's hard work in staying up with the assignments and getting things done the way they need to be done. That's important for all of us. So if you don't have any questions, last chance. I'm going to stop the sharing of that, and I'm going to say I will see you next Monday night in class, Kirschman Hall. You all have a good night.